Thank you, Ellen. Earlier in the day, Luigi Ferrucci, I think probably in a sense of slight frustration, it was in one of the sessions when we were talking about methods, said, what about the elephant in the room? What are you actually going to do? Well, ladies and gentlemen, I am the elephant in the room, because it is my job to tell you what we're actually going to do. And a lot of what I'm going to say, or some of what I'm going to say, you will have already heard, because we've, during the course of the day, heard a number of suggestions around how care needs to change. And the work that I'm going to describe to you was funded by the Commonwealth Fund and entitled Designing a High-Performance Healthcare System for Patients with Complex Needs. Now, I don't want to go into the overlap between multimorbidity and patients with complex needs, but I am talking about a subset of people with multimorbidity, because I don't think principally in the room today we're talking about a quite typical patient with multimorbidity. I'm a 66-year-old man. I have 3 chronic conditions. I very rarely go and see the doctor, and I have no disability. So I don't actually think we're talking about people like me. We are talking about people with complex needs. Now, this piece of work was started off with a literature review that was led by the London School of Economics and an analysis from models around the world. And then an international working group from these countries, from the US, the States, Germany, Israel, and so forth, including Mika from the Netherlands and myself from the UK, met on 2 occasions during the course of this study for 2-day meetings in London where we thrashed things out. And we came out with 10 recommendations for policymakers that we presented to OECD health ministers at the beginning of last year. So that is what I'm going to talk about. I'm going to give you the 10 recommendations for policymakers on how you need to organize your healthcare system for patients with complex needs. And the aim was 3 things: improved care, improved outcomes, and if you're going to talk to policymakers, there's no point in imagining that they're not also interested in cost containment. So that was the triple aim that we were trying to address. And I assume the slides will be available, but that very long and completely ridiculous website address at the bottom is where you will find the full report of our work. So, number 1, recommendation: you need decent information systems. First, routine, high-quality exchange of information. I'm sometimes astonished at how poorly people exchange information between sectors. And we've tried to address this in the UK, so it is now mandatory in the UK that hospitals send a discharge summary of a patient electronically to the GP within 24 hours of discharge, and within 2 years it will also be mandatory that a letter from the specialist when they've been seen in an ambulatory care setting also goes to the GP within 24 hours. So we've got to get used to exchanging information. Well, we gaily said integrated medical records. And again, if I give you the example of the UK, it shows the best and the worst. We have fabulous primary care records with effectively a single electronic record which is shared between primary care practitioners. And when the patient moves from one GP to another, the whole of his life's record moves with him. In contrast, our hospitals are a complete disaster. They have attempted to get a common record system and have utterly failed, and the whole thing is a shambles. But mind you, it's a lot better than when you talk about sharing between different sectors. And in many countries, the barriers that exist between health and social care are very considerable. And I'll say a little bit more about that later. But information is very important to providing good care for this group of patients. Second, workforce planning. So the workforce needs to meet the needs of this population, and it needs to be based on competencies and not traditional professional boundaries often get in the way of what these people need. For medical schools and postgraduate training, they need to give a much higher priority to generalist training, which principally means primary care doctors and geriatricians. The Canadian on our working group gave the remarkable statistic that in Canada, there are 10 times as many pediatricians as geriatricians. And that will not meet the needs of the Canadian population. Our third recommendation is around patient selection and targeting. And this nice quote, I'm sorry I've forgotten who it's from, but you can integrate all of the services for some of the people, and you can integrate some of the services for all of the people, but you can't integrate all of the services for all of the people. So we have to be a bit realistic about what we can actually do. And of course, there have been a whole series of attempts, particularly to profile populations that need to be given particular approaches to more coordinated or more integrated care. And a whole bunch of risk profiling algorithms around that are either data-based from electronic medical records, or they incorporate some professional judgment, or a bit of both. And the principal problem, without going into it, but I'd be delighted to give you a lecture on it anytime anyone wants to invite me, is they're not actually very good. And they're not usually as good as the promoters of those risk models say they are. So they're very good at predicting what's happened. So if you want a measure that tells you who was at risk of being admitted to hospital last year, that's actually quite straightforward. But predicting who will be admitted to hospital next year, or particularly the year after, the models suddenly get a bit more flaky. So we have models, but they're not very good. The fourth recommendation is about patient engagement. And we've heard several times today about how evidence-based guidelines break down for many patients with multimorbidity, leading to overtreatment and the attendant complications that we're all familiar with. And so patient preferences are key to this. And as Mary Tinetti said, called it patient priority aligned care. And I think we are still very bad at this. I think we're not just bad at it, I think our juniors particularly are quite frightened. So they've grown up in an area where clinical guidelines look to be mandatory. You're doing something wrong if you don't follow the guideline. Indeed, you may be hauled over and criticized and may even have your license threatened if you don't do these things in the guidelines. So I think we have got a very substantial education program which starts right at medical school, where people are still taught in a way which does not bring in the priorities of patients being key. And so shared decision making again becomes the norm, again something that we are not necessarily good at. Personalized medicine, great idea, and by the way, for all the people in my intensely biomedical medical school in Cambridge, that does not mean genomics. The fifth recommendation relates to involving caregivers, and we often forget that caregivers, spouses, children and friends, provide an enormous amount of care. And a lot of what we are able to do depends on them continuing to provide care. So their contribution needs to be recognized through training. And of course, caregivers sometimes provide astonishingly complex care these days. You were probably all familiar with parents who bring their children home on ventilators now, which was unheard of 10 years ago. So they may need training, they certainly need support, and they may need respite care. They may need recognition that actually they need a break too, because often their own needs fail to be recognized. They don't go and see the doc for their own problems, and then something breaks down with a carer, and the patient who you were trying to look after ends up in institutional care because their carer can no longer manage. So these are key parts of the equation. Fifth is around coordinating care, and it's very easy to be glib with phrases about this and phrases that don't always work very well. So I think we would all in this room acknowledge the need for well-coordinated care for people with complex problems who often have needs that are met from different parts of the healthcare system or health and social care. But how do you actually do this? Well, there are a whole number of we're very, very good at, in the UK, and maybe you are in your countries also, at having great national plans that we're told will happen, and then somehow they don't quite reach the desire of the politician. Care plans are actually a good example. So we had an instruction, I'll call it that a certain group of the population should have care plans in their GP records, and indeed they did. And boxes were ticked. The patients had no idea they had such a thing as a care plan in their records, and it's very unclear that anything very much was implemented. On the other hand, you can absolutely see the need for, if I give you the example of end-of-life care, in my own patch in Cambridgeshire and Peterborough, we do indeed have care plans in GP records that are in district nurse records that are shared with the patient, that can also be accessed by the ambulance service, by the out-of-hours care, and by the A&E department. And those are really important things in order to express the preferences of patients for particular types of care in circumstances that might need to be planned for. I think the issue about care coordinators, who I also mention here, is a very moot one, but certainly a whole range of places have experimented with having a particular person to coordinate care. Now, whether that's somebody who's a professional care coordinator. Some of you in the room might think that actually the general practitioner is the care coordinator. Maybe that's precisely the role they should be taking. And in other settings, people choose the care coordinator in relation to the patient. And it might be a social worker, it might be a physiotherapist, or it might be a GP, depending on the needs of the individual patient. And this, of course, brings to the fore the need for effective multidisciplinary team working. And I won't go into all the many problems of that. Again, it's very, very easy to say. But how you provide that sort of team-based care. In the UK, we do a number of things to actually actively make it more difficult. So we used to have community-based nurses who were directly attached to family medicine practices. They're no longer. We used to have psychiatrists who related to particular practices, but they now seem to be split into different ways. So sometimes we organise our healthcare systems to actually make it more difficult. We've talked quite a lot about continuity of care, both the need of continuity of information, continuity of management, and continuity of staff. So I won't go into that anymore. Recommendation number 7 also relates to coordination or integration, but we did specifically point out in this report 2 major fault lines in integration. The first is between physical healthcare and mental health care, a major problem in many countries. And one of the potentially good things that has happened in the UK in the last 2 years has been the promise by government to put a mental health care worker into every primary care practice in the country. That's England. That's a person who would both provide mental health care but also link to the wider mental health services. But also the very major fault lines between healthcare and social care in many countries. We look to Scandinavia as the model for how you do it, and we certainly in my country utterly fail. 8th, we're getting towards the end, engaging healthcare leaders, because the recommendations I've talked about actually require profound change in what health professionals we train, how they're trained, how they work together, how they communicate. And the simple fact is that most initiatives to coordinate care, as Mika showed in her last slide, don't work very well. Some do. And leadership for change, especially clinical leadership, is absolutely critical. And I think if you look at things, individual examples of things that have worked well, they've often had a clinical leader at the heart driving things. So we need to engage clinicians and other staff in change at all stages in their career. And again, this goes back to medical school training. We're not just teaching medical students facts that are going to get out of date. We're teaching them how to organise and how to run and how to be leaders in a healthcare system, small or big. Number 9, we need to align funding and incentives because, predictably, but alas, payment systems produce predictable results. So, rather too much on this slide, but if you pay doctors by salary, there are 4 ways of paying doctors, that will provide them with a basic secure income but provides no incentive for population coverage, improving access or quality. The second line, if you pay them on capitation, that's great because you'll get coverage for the whole population. That will promote equity, but provides no incentive for good access if patients are technically registered or to improve quality of care. The third line, if you pay them on fee-for-service, which of course is the main way of paying doctors across the world, that prioritises meeting demand and will do so effectively, but risks, of course, over-provision, whether or not care is needed, and we know many examples of over-provision. And finally, pay for performance, which produces some improvement in quality, but usually much less than the payers think that it will do, but neglects aspects of care that are not measured or incentivized and carries the attendant risk of prioritizing care of individual conditions over the patient as a whole that we have talked about this morning. So from terms of payment system, universal healthcare coverage is absolutely essential. Fee-for-service will not meet the needs of multimorbid population, and so payment systems need to encourage coordination and cooperation, which may include bundled payments, may include risk-adjusted payments to avoid the sort of hot potato issue that Cynthia was mentioned. And also, please tell your politicians that better care does not always save money. Finally, when we're enabling innovation and learning, it's very clear that we need to understand there's no silver bullet for what works best, and that the effectiveness of interventions may well be context dependent, both within and between countries. And we've heard about some of those contexts today. And the other things to say to your politicians or policymakers who are introducing these changes is that interventions, especially those that require a change in culture or a change in working practice, take a long time to bed in. It will often be 18 months or 2 years before you see improvements if what you're looking for is a change in the way in which people work or work together. So if your intervention study is designed to measure outcome from 12 to 24 months, you'll probably miss the change. So people who introduce change really need to understand this. So there we are. There are 10 recommendations for a healthcare system that will deal with these people with complex needs. Acknowledgements to the Commonwealth Fund who funded the study, to Martin Wenzel and Elias Marsalis from the LSE who led the work, and the international group, including Mika, who were on it. Thank you very much.